Good afternoon, and welcome to the prenatal through age 25 behavioral health legislative implementation webinar with Q&A today. We're glad that you are here. I'm going to give it just a few minutes while people are still logging in. So thanks for joining us today. All right, a few housekeeping things as we get things started. We do ask that you please mute yourself if you're not speaking, so it's not a distraction to the presenters. Raise your hand if you would like to speak. We do have people who will be monitoring that. Remember, this time is for you. We welcome any and all questions and all feedback. This is definitely a place for you, and hope that it's an inviting, safe place for you to share as we share with you. We do ask during the presentations that you add your questions to the chat, or try and remember them, as I tend to forget, and because we'll be doing them at the end during the Q&A. If we can't get to your question in this call, we will follow up after the meeting with you directly. Just a disclaimer, this meeting is being recorded and will be posted to our prenatal website on HCA. It is open to public disclosure, so do not provide any private or confidential information. We do have a robust agenda today and a variety of presenters. So we're glad you're here. I'm going to turn it over to Liz Venuto, who is going to set the stage and set the expectations for the meeting today. Liz.
All right. Thank you so much, Jennifer. Thank you all for joining us today. My name is Liz Venuto, and I am welcoming you on behalf of our section manager, Diana Cockrell. We have the pleasure of supporting the amazing work of the Prenatal through 25 Behavioral Health section at the Healthcare Authority. Some context and framing for this particular update series. In the 2022 legislative session, House Bill 1800 gave resources to the Healthcare Authority to support communications for the prenatal through age 25 behavioral health section within the Division of Behavioral Health and Recovery. This is our second year.
That might be, again, you could.
This is our second year of being able to share updates on work we're implementing in this way. We have 10 to 15 implementation initiatives coming out of the section from past sessions. Today's presentation and Q&A will be on our legislative initiatives, so things that have come out of legislative sessions. And with that, I want to give a nod to an equal number of programs others on the team also lead from Washington that are not reflected here. So the work of this group is really broad, and this is just a snapshot. For each implementation presentation, you'll hear a bit about the language in the bill or budget proviso that funded it, a rough timeline for the work, and where we are in the process of rollout. Please participate freely in chat as you like, and we'll either respond in chat if it's connected to legislative implementation, gather to follow up with you afterward if it's connected to other work, or feel free to save the questions for the Q&A. And again, thank you so much for joining us today. Team, thank you for your courage and willingness to step into the challenge of presenting your work today in this format. And with that, I'll turn it back to you, Jennifer. Thank you.
Wonderful, thank you, Liz. So today's presentation begins with Larissa, who will take us through the Children's Long-Term Inpatient Program, otherwise known as CLIP. Larissa.
Hello, I get to start us off today, and my name is Larissa Foray, and I work with Healthcare Authority in the P to 25 unit. I use she and her pronouns, and like Jennifer said, I am the Children's Long-Term Inpatient Programs Administrator, otherwise known as CLIP. I am here to share our most recent updates regarding the CLIP bed capacity expansion and the CLIP rate increase. So next slide, thank you. We're going to start with a quick overview of what CLIP is. So CLIP is the most intensive, restrictive, long-term psychiatric inpatient course of treatment available in our state to children and youth ages 5 to 17. CLIP is funded with a 50-50 Medicaid match, state and federal. CLIP is a planned course of treatment that provides multidisciplinary psychiatric treatment. The goal of CLIP treatment is to transition children and youth back to their homes and families and communities once clinically indicated. Funding was provided in fiscal year 2022, starting in fiscal year 2022, to begin expanding the contracted CLIP bed capacity. And by contracted, I mean those programs that are the CLIP programs that are not CSTC CLIP beds. So Pearl Youth Residence beds, Two Rivers Landing, and Tamarack, those types of providers. However, the pandemic significantly delayed our efforts in expanding bed capacity due to workforce shortages, increase in operation and labor costs, and delays in permitting and construction and licensing. Expansion efforts continue to support 46 additional contract CLIP beds. That does not include CSTC bed capacity. The daily rate was also increased 31%, which became effective January 1, 2023. Currently, there are average of 51 available contracted CLIP beds, not including CSTC. And utilization changes daily with a monthly utilization average of about 40 beds, not including CSTC. So current capacity expansion efforts include continuing to identify potential providers. Efforts are also underway to release a procurement to identify potential providers that we may not know about or have already touched base with. And we do have some interested providers that are moving through the licensing process with no current ETA to share at this time. Currently, provider challenges include some of those factors I listed previously, but continue, such as workforce shortages to maintain safe staffing levels, hiring and retaining staff, especially nurses, and lengthy processes in licensing and construction. So thank you for your interest and your time. And at this time, I'm going to turn it back over to Jennifer.
Thank you, Larissa. Next, we'll turn it over to Rachel Baxter to discuss the rapid housing response for youth and young adults.
Hi there. Excuse me. My name is Rachel Baxter, and I work with the Healthcare Authority as the Behavioral Health Stable Housing Policy Lead for Transitional Aged Youth. I'm discussing the Youth and Young Adult Housing Response Team, previously known as the Rapid Response Team. So just a little history. In 2018, legislature expressed a goal that beginning in January 1st, 2021, any unaccompanied youth discharged from a publicly funded system of care would be discharged into safe and stable housing. The Office of Homeless Youth and the Department of Children, Youth, and Families were tasked to develop a plan supporting that goal. This report was completed in 2020 and is titled Improving Stability for Youth Exiting Systems of Care. With that report in mind, legislature passed Senate Bill 6560 to be put into law that no young person exiting a system of care would be released into homelessness. As a continuation of that work, House Bill 1905 was passed in 2022, which requires relevant state agencies to work together as part of the Youth and Young Adult Housing Response Team, also known as the Rapid Response Team. The Youth and Young Adult Housing Response Team was spearheaded and implemented by the Department of Children, Youth, and Families in equal partnership with the Office of Homeless Youth, the Healthcare Authority, the Developmental Disabilities Administration of the Department of Social and Health Services, and is tasked with creating a cross-agency group who will collect, track, and report data related to gaps and barriers to stable housing for young people exiting publicly funded systems of care. This includes the behavioral health systems, juvenile justice, Office of Homeless Youth Programs, and the child welfare systems. DCYF will receive all referrals to the YART for individual youth and young adults in need of resources to be able to attend those housing stability conversations. The Youth and Young Adult Housing Response Team completes case conferences and the coordination of resources to youth and young adults, families to secure appropriate housing and other support as they exit a publicly funded system of care. In addition, services and support must incorporate young adult voice and choice and be responsive to the individual needs of each young person. Unlike other system meetings, such as multi-system rounds, YARC case conferencing meetings are centered on youth and young adult participation to establish their own housing goals. The response team convenes weekly with case conferencing happening twice a month and the other meetings to discuss cross-system planning. As part of the creation of the YART team, HCA received $427,000 from the General State Fund, which funded 3 positions that were created. Those positions are an occupational nurse consultant, a research manager, and my position as the Behavioral Health Stable Housing Policy Lead. 2 of these positions, the nurse consultant and myself, are core team members to ensure that any behavioral health programs have been referred to, that the managed care organizations are also part of the creative problem-solving conversations, and to address any technical assistance as needed in the future. Each member and some managed care organization members have completed the diversion training with Away Home Washington to learn how to engage in creative conversations to identify and establish possible housing options. Additionally, to gain access to the Youth Diversion Infrastructure Project, also known as YDIP Flexible Funding, they each completed that training at Away Home Washington. This initiative was created to support young people financially to mitigate any barriers to housing. This fund can be utilized by the young person, a community provider assisting with discharge, and/or individuals, including landlords. YDIP funding is currently available within Clark, Pierce, Spokane, Walla Walla, and Yakima counties. Other community members that work with young people are also able to access the funding upon completion of the training. The following individuals can refer a young person to the Youth and Young Adult Housing Response Team: either the youth themselves, a family member, a case manager, an advocate, an educator, law enforcement, an OHY provider, and any contracted service providers that is working directly with the youth or young person. On this slide, you will find the referral form and the website information. When you have completed the referral, please ensure that the young person is being exited from a system of care and has not identified safe or stable housing. Once the referral is completed, the Youth and Young Adult Housing Response Team manager will reach out to the referent to gather any additional information and to complete a release of information so that the team is able to discuss possible resources that may be beneficial to that young person. The manager will also identify any initial gaps or other possible programming the young person may qualify for. The manager will make connections with the related agency team members as well. After a plan is made, the manager will continue to follow up with the young person over the course of a year to ensure housing stability has been maintained. On the website, you will also find contact information for each of the core members and the agency that they are associated with. Thank you for your time, and I'll return it over to Jen.
Thank you, Rachel. You did a lovely job. Again, just to reiterate what she said, the slide, when these go out and will be online, does have the links to the website to learn more about YART and also the referral form for you to use. I now have the joy of introducing Shelby to talk about the New Journeys expansion. Shelby.
Hi, good afternoon. My name is Shelby Terry. I'm the program administrator for First Episode Psychosis alongside program manager Becky Daughtry. Psychosis refers to a cluster of symptoms that impact an individual's perception of reality and interferes with their daily functioning. Individuals may experience delusions, such as false beliefs. For example, they may think people on television are sending them special messages or that others are trying to hurt them. They may also experience hallucinations, like seeing or hearing things that others do not, or voices telling them to do something or criticizing them. Other symptoms can include incoherent or nonsensical speech and behavior that is inappropriate for the situation. These experiences are more common than many people realize. Each year, it is estimated that more than 2,000 youth and young adults in Washington experience a first episode of psychosis. The longer psychosis goes untreated, the more severe and chronic a person's symptoms may become. Examples include increased rates of dropping out of school, increased substance use, more visits to the emergency department, additional hospital admissions, risk of legal trouble, risk of becoming homeless, and increased risk of suicide or premature death. The average lifespan of people with major mental illness is up to 32 years less than for general population, largely because of increasing risk of multiple chronic disease. However, there is hope. Research shows that early psychosis is identified and treated, the more likely someone is to experience a remission of symptoms resulting in improved daily functioning for the individual and a decreased financial burden to the healthcare system. Coordinated specialty care is the best evidence-based practice for first episode psychosis. In 2015, New Journeys was introduced to Washington's own coordinated specialty care model. This vital treatment provides access to services as soon as symptoms emerge, rather than waiting for someone to become severely or chronically ill. It involves a multidisciplinary team providing a full range of person-centered, community-based services that include an individual's natural supports. The treatment also includes a public education and outreach function that is intended to hasten the identification of rapid referral of youth and young adults experiencing a first episode. New Journeys challenges historical ways of thinking about major mental illness, which often include limiting beliefs and expectations of someone once they've been diagnosed with something like schizophrenia. New Journeys doesn't do that. Instead, this model offers hope and real help to young people during one of the most vulnerable times of their lives. With this knowledge, we know that recovery from psychosis is possible and early intervention saves lives. Next slide. In recognition that delaying treatment can result in loss of family and social supports, disruption of employment, substance abuse, increased hospitalizations, and reduced prospects for long-term recovery, the United States directed in 2014 that set aside funding from the federal mental health block grant be used to help develop first episode psychosis treatment programs. In 2019, the Children, Youth, and Family Behavioral Health Work Group advocated for Second Substitute Senate Bill 5903. This legislation called for creation of the New Journeys Implementation Plan for Evidence-Based Recovery Supports, development of financing strategies for Medicaid, and statewide expansion of New Journeys based on incidents of first episode in Washington's population. The New Journeys Implementation Plan was submitted to the legislature in 2021. This provided a roadmap for financing and expansion of New Journeys. Several of the service components that are included in New Journeys are difficult to fund using conventional Medicaid or commercial insurance. Treatment teams have been financed using mental health block grant 10% set aside and state funds. As directed by legislation on July 1st, 2022, funding for New Journeys was moved from mental health block grant to Medicaid through the implementation of team-based rate, which was developed through an actuarial process using New Journeys service utilization data. State funds are directed to support those who are uninsured or underinsured and services not covered by Medicaid. The statewide plan also emphasized the need for future legislation to mandate commercial parity to ensure these evidence-based interventions are available to those in need. Next slide. There are currently 15 New Journeys teams across 9 regional service areas in Washington. Based on these numbers, there is a clear need for continued expansion of New Journeys services to those areas in Washington at risk of being underserved. As we continue expansion through our state, we are focusing on increasing equitable access to treatment for first episode. These efforts will address diversity, equity, and inclusion with the evidence-based work by targeting culturally responsive adaptations of the existing model. These adaptations will aim to better serve those who are American Indian and Alaska Native and those living in rural areas where access to resources may already be limited. In sum, New Journeys is cost-effective and highly beneficial to those experiencing psychosis. Support of this model is aligned with value-based care delivery by redirecting usage of costly inpatient care to lower-cost outpatient clinical services and supportive services. New Journeys breaks down the barriers created by stigma of major mental illness. The emphasis on community education, early screening, and a no wrong door approach to accessing treatment helps remove the silos often seen in traditional outpatient treatment. Thank you for your time. This concludes my presentation.
Thank you, Shelby. Next, we have a full team of Ashley Pina and Sarah Pine, who will talk through pregnant and parenting women in the Child Assistance Program. Ashley.
Hello, everyone. My name is Ashley Pina. I am the Pregnant and Parenting Family Substance Use Disorder Policy Administrator in the Division of Behavioral Health and Recovery. I'm going to start the presentation this afternoon by sharing the proviso language that supports this combined effort to increase the number of substance use disorder treatment beds for pregnant and parenting women and parent and child assistance program, also known as PCAP, client slots. I will provide an overview of pregnant and parenting women's services, and my colleague, Sarah Pine, will cover PCAP services. Next slide, please. The funding provided on a phased-in basis to increase the number of PCAP case management slots by 56 and to increase the number of PPW, pregnant and parenting women, residential treatment beds by 16 in the year 2025. The outlook assumes an additional 32 pregnant and parenting women residential treatment beds are phased in through the year 2027. Next slide, please. Pregnant and parenting women's services are designed to meet the needs of pregnant and parenting women seeking services. Pregnant and parenting women are a priority population for the federal substance abuse block grant funding. PPW services include inpatient and outpatient substance use disorder treatment. Residential substance use disorder treatment is available to women and their children under the age of 6 for up to 6 months. Structured clinical services are provided in a planned regime of patient care in a 24-hour live-in setting. There are 8 PPW substance use disorder inpatient programs in Washington State, located in Snoqualmie, Yakima, Thurston, and Clark County. Next slide, please. The current status of this portion of the proviso starts with a procurement process. The procurement type is a request for information set to start in January. This is also known as a RFI. There's a potential for multiple contracts with this RFI. The audience for this procurement type is substance use disorder residential treatment providers. The procurement start month is January 2024 with the goal to have a provider identified by June 30th, 2024. This concludes my portion. I will hand it over to my colleague Sarah Pine to provide an overview of PCAP services and her role in increasing PCAP client slots. Thank you so much.
Thank you, Ashley. I'm Sarah Pine. I'm using she, her pronouns, and I am the Pregnant and Parenting Women's Behavioral Health Program Manager with the P through 25 unit. I will be discussing the task on PCAP expansion identified in this budget. Next, oh, we're good on the slides. The Parent-Child Assistance Program, commonly known as PCAP, is a 3-year intensive case management program. There are currently 15 locations statewide, serving a total of 20 counties, and currently contracted to serve 1,490 clients. PCAP is funded by both Medicaid and state dollars. Next slide, please. PCAP assists clients in learning to access and use local resources that cater directly to each client's individual needs. This also includes receiving treatment, establishing recovery, and supporting parents with their child's individual needs as well. Next slide, please. DBHR and DCYF have a long-standing interagency agreement that has supported PCAP to serve DCYF-involved clients whose child receives a substance-affected newborn, SEN, diagnosis. There are 4 locations that have been identified as areas of high parent-child DCYF involvement with SEN diagnosis. These 4 sites are King, Yakima, Spokane, and Clallam-Jefferson. Each location currently dedicates 14 client slots for these families. Next slide, please. The current budget identifies $603,000 per fiscal year to double the capacity dedicated for DCYF-involved PCAP clients. This would be an addition of 56 client slots by the end of fiscal year 2025. We are currently partnering with the participating PCAP providers and DCYF to determine the expansion agreements. We estimate final agreements to be determined within the next 4 months. Thank you for your time. I will turn it over to Jen.
Thank you, Sarah and Ashley. We like that you keep in mind our itty bitties with this work. I now have the honor of having Liz Menudo present on behalf of Pedro Garcia, the Residential Crisis Stabilization Program for you. Liz.
Hi, so I'm Liz Menudo. I'm a supervisor in our Prenatal-25 Behavioral Health section, sharing on behalf of Pedro Garcia, the program administrator. Today, I'll be going over the Residential Crisis Stabilization Program, RCSP for short. By the end of the next few minutes, I hope to answer the following questions. What is the RCSP? Who is it for? What does it cost? And what can you expect? And then lastly, the project status and what's next. Next slide. This program is designed to provide 24-hour treatment for children and youth who are experiencing a behavioral health crisis. This crisis may be related to substance use disorder or mental health conditions. The overarching goal of the youth stay in the RCSP facility is to stabilize the youth enough for one of the following: a return to home, discharge to another community setting, or a transition to a higher level of care. Discharge planning begins at the time of admission. And while in the facility, youth receive trauma-informed and evidence-based care that is therapeutic in nature and includes medication management and opportunities for recreational and social activities. There are also opportunities for family therapy and parent-to-parent peer support. In other words, this is meant to be a one-stop shop to meet the needs of young people and their families in crisis. So in this next section, we'll be looking at who it's for, the cost, and what you can expect. So first, who is this program for? The population of focus for the program are young people between the ages of 5 and 17 residing anywhere in the state of Washington, experiencing an active behavioral health crisis. They do not meet admission criteria for inpatient hospitalization or involuntary treatment. And this facility is designed for co-occurring mental health, substance use, and neurodiverse individuals. The RCSP is designed with the intention of inclusion for young people experiencing autism spectrum disorder and individuals with intellectual and developmental disabilities. So in the program cost, we've been legislatively directed to develop up to 2 facilities, one on either side of the Cascade Mountain Range, each with a capacity of 16 beds. So in total, we're looking at having 32 beds available statewide. According to our financial modeling, it's expected to cost about $818 per person per day. With this figure, we can assume it costs, as you can see on the slide, 4.7, I always get tripped up on the numbers, 4.78 million to operate one facility with 16 beds. And we also need to account for startup costs at just over $709,000. The total cost would then be around 5.49 million for the first year and 4.78 million annually after that. The next slide, finally, what specific services can you expect? A full array of services to stabilize the current crisis and to offer support to get a good assessment. So these include things like case management and care coordination, therapeutic activities, medication management, group therapy, individual and family therapy, skilled behavior management, recreation therapy, and educational support. There's also a whole host of medical and behavioral health professionals on-site or contracted to provide as many of these services as possible in one place. As you can see, the range of professionals is broad and designed to meet the diverse needs of individuals and families. So next slide, this project has been under development since 2021, when the legislature allocated $12 million to the Department of Commerce to distribute facility construction grants. However, this is such a new program and it doesn't yet exist in Washington in any form. So after 2 separate requests for proposals for capital funding, we've been unable to attract a service provider that has the necessary expertise and resources to operate this kind of facility. A third request for proposals for capital funding is not planned, and the capital funds are now forfeited. But we're not going to stop there. The legislature also allocated $5.4 million in operational funds for state fiscal year 2024. These funds were allocated to follow the capital dollars to support readiness, program implementation, and operational functions. We're now looking at leveraging operational funding to pursue direct contracting opportunities with 1 or 2 capable providers. So at this stage, the Division of Behavioral Health and Recovery subject matter experts have convened to reassess the fiscal model for a pilot program, with a priority of including youth and family voice in the program development. This is a facility that our community is asking for, and we hope to find the right partnerships to truly make it a success. And with that, I will pass it back to Jennifer.
Thank you, Liz. Also, a big thank you for stepping in for Pedro, who is dismissed for this program and was unable to be with us today. So thank you, Liz. I'm now going to pass it to Sunny, otherwise known as Sonia, to talk about the intensive outpatient and partial hospitalization program. Sunny.
Hello, thank you, Jennifer. I appreciate that introduction. So hello, I am Sonia Salazar. I work for DBHR in the P25 section. I do use she, her pronouns, and I am the program manager for our intensive outpatient and partial hospitalization pilot programs. So to abbreviate, I'll be using IOP to reference intensive outpatient program and PHP to refer to partial hospitalization program. Next slide, thank you. To start with a little bit of background, the pilots were requested through legislator and were to begin services in 2021. This is with the support of Senate Bill 5092 and Senate Bill 6168, also referred to as Proviso 76. This bill and proviso required HCA to implement 2 pilot sites for IOP and PHP services for certain children and youth under the age of 21 in the state of Washington. The 2 pilots needed to be contracted with a hospital that provides psychiatric inpatient services to children and youth in a city with the largest population east and west of the crest of the Cascade Mountains. Our current location being Seattle Children's Hospital and Providence Sacred Heart in Spokane. The pilots prioritize children and youth discharged from an inpatient hospital treatment program who require the level of services offered by the pilot programs in lieu of continued inpatient treatment. Services may not be offered if they are less costly alternative community-based services that can effectively meet the needs of an individual referred. Within both pilots, each program has its own target population, which must be met for the child to be admitted to the program. We were able to add a 3rd pilot site due to legislation in fiscal year 2022, allowing us to expand to multi-care behavioral health Burien location, in which all of this applies as well. Let's go ahead and take a look at difference in services. So IOP services and PHP services have some similarities, as you can see in the slides. The main area I'd like to really focus on is the days and hours offered per week. IOP offers a very structured treatment, 2 to 4 hours per day and 3 to 5 days per week. This is less intensive than a PHP, with which the patient must participate in structured treatment activities, including individual, group, and family therapy, 5 to 8 hours per day, 3 to 5 times per week. So child and youth mental health partial hospitalization care will not exceed 45 days, whereas IOP length of treatment does not exceed 30 days. Next slide, please. The timeline of the pilot, how we grew during the past few years, has been building and adding and reevaluating programs to see how things may look when we officially have services in the state plan. Seattle Public Schools has been able to offer over 7 different programs, and with the data and outcomes has also been able to modify and continue the services of their current 3 programs being offered at this time. Providence Spokane is offering both IOP and PHP for 2 different age groups, age 8 to 12 and also age 13 to 21. And MultiCare is providing a PHP that will serve youth age 13 to 19. Next slide, please. The pilots have been very beneficial in services throughout Washington, as well as assisting with data and rates that will influence the state Medicaid plan. With the work the pilots have done, we've been able to see an indicated decrease in dollars after discharge for patients, as well as an increase in days diverted for inpatient stays due to services offered by the pilot. Next slide, please. Alongside our actuarial partners, Mercer has completed a final legislative report to bring forth any trends, solutions, and final rate suggestions for the Medicaid state plan. Through this report, we have been able to develop an FAQ billing guide that also has SERI and fee-for-services rates all through for the managed care organizations and behavioral health agencies. The pilot did not require a state amendment and can be used with the set program structure for the early and periodic screening, diagnostic, and treatment services. Managed care organizations have been provided the FAQ and are planning to utilize their services alongside all recommendations that have been put in place. The negotiation for rates will be between managed care organizations and the IOP and PHP providers. The work with the FAQ and the transition into the state plan has been completed by our team of leaders in HCA, and we are looking forward to the smooth transition into the state plan starting on January 1st, 2024. Thank you, and I'll go ahead and pass this presentation back to you, Jennifer.
Thank you, Sonia. Last but certainly not least, we bring you what a lot of us are talking about in the DBHR world, the Youth Mobile Response and Stabilization Services Program and how it ties in with 988. Ms. Sherry Wiley.
Thanks, Jennifer. Hi, good afternoon. My name is Sherry Wiley. I'm the Youth Mobile Crisis Team Administrator here at DBHR on the Crisis Systems team. And we're working with DOH and the Governor's Office on rolling out the enhancements related to 988. So I'm going to go over recent legislation as it relates to the crisis system, and then I'll talk about the youth model. In July 2020, the federal government passed legislation that made 988 the number to call so that we don't have to remember that 10-digit number. 988 went live in Washington State last year, and calls to 988 are being answered in state by 3 national suicide prevention lifelines. They're NSPLs for short. They do great work, and they're confidential by nature, and they have an impressive over-the-phone resolution rate. In 2022, SAMHSA released a best practice crisis care toolkit for both adults and youth, and NASHBID released a safe place to be about stabilizing youth in the community as best practice. Next slide. In 2022, Washington passed House Bill 1477. This establishes the Crisis Response Improvement Strategy Committee, the Steering Committee, and subcommittees. It also calls for technology and crisis contact center hubs to eventually dispatch crisis teams for callers to 988. This year, House Bill 1134, previous slide, added a geolocation subcommittee and ensured a vote in the steering committee for the lived experience subcommittee seat. It also created a voluntary endorsement for mobile rapid response crisis teams, which include youth mobile crisis teams, to receive an enhanced case rate and performance payments if response times are in the bill are met. Next slide, please. In 2022, proviso funding went out to ensure at least 1 adult and 1 youth team in each region to respond to calls coming into 988. Healthcare Authority contracts with 10 regions to provide crisis services. A SAMHSA System of Care grant is supporting youth team rollout in 2 regions. Next slide, please. So this time last year, we only had 4 youth mobile response crisis teams in the state. We've tripled the number of youth teams to 12, and we've tripled the counties with a dedicated youth team from 5 to 15. The System of Care grant is supporting rollout in Pierce and Spokane. Since 2022, Washington has been participating in a national quality learning collaborative with other state leaders in youth crisis and MRSS. and system-level partners for technical assistance on youth best practices. The youth best practice model is called Mobile Response and Stabilization Services, and for time, I'll be using the acronym MRSS for the rest of the presentation. Next slide, please. The adult crisis model in SAMHSA's toolkit consists of someone to call, someone to come, and somewhere to go. For youth, we don't want to transport them anywhere. So the somewhere to go becomes a safe place to be, sometimes also called a safe place for help. MRSS teams bring the entire crisis continuum into the home by providing both crisis intervention and crisis stabilization in the home or wherever the youth is. Next slide, please. The goals of MRSS are to intervene early and at the interruption point that leads to more restrictive facility-based care. We want to reduce the use of emergency departments, inpatient stays, or juvenile justice involvement for behavioral health needs. Teams do this by supporting and maintaining the youth in their current living situation. Kids sleep in their own beds, not in facilities. They promote safe behavior in homes, schools, and communities, and assist families to access resources already available to them in their community. They break down barriers to care through outreach and engagement. Next slide, please. There are two phases to MRSS. MRSS meets a sense of urgency with urgency. When families call, teams go. They respond with a clinician and a parent or youth peer, and they provide developmentally appropriate engagement, de-escalation, safety planning, and can help support caregivers in restricting access to lethal means. This team can follow up with that family for 3 days. Next slide, please. If there are still more needs, then there's a separate but connected in-home stabilization phase for up to 8 weeks. During this phase, the teams continue their safety planning, psychoeducation, skill building, and they work with the family to identify and connect them to natural supports in the community through wraparound principles. Teams will make referrals and provide warm handoffs to the right level of clinical care to ensure connection. Next slide, please. This slide shows on the left each of the 10 regions we contract with to provide crisis services. And the graph shows you how many days youth currently get when they access the crisis system. All kids in the state get that crisis intervention phase that's in green. 2 regions are providing the stabilization phase, which are King and Thurston Mason, and this is being done through braided unsustainable funding. This local funding also creates data issues. If HCA isn't funding the program, the data is not getting sent up to the state. Pierce and Spokane are providing stabilization through the System of Care grant. The graph on the right is the goal. This is future state, that all youth get the full MRSS package when they activate the crisis system. And we're working on a state plan amendment to expand stabilization from the current 14 days to 8 weeks. We expect a go date of January 1st, 2024. Next slide, please. So how are families accessing crisis services? This picture tells the story. This is how they are accessing the crisis system. All these people in the middle, the family, the parent caregiver, the schools, the primary care provider, all of the system of care partners like existing providers, they all tell families to take the kids to the emergency department when they're having behavioral health needs. When a caregiver calls a crisis line and we don't send what looks like help, they're going to hang up, they're going to call 911. 911 is going to dispatch EMS or law enforcement. Both of those will transport the youth to the emergency room. Sometimes they'll get transported to juvenile justice. Washington State has a well-known adolescent hospital boarding issue. Hospital 1580 passed last year, creating a multidisciplinary team led by the governor's office to address this. This team is directed in the legislation to connect the youth in the hospitals with these mobile rapid response crisis teams in 1134. A 2022 study by Mary Bridge Emergency Room in Tacoma found that for youth who went to the ED for behavioral health needs that year, 61% of families reported negative functional impacts associated with the long length of stay at the ED. 33% of youth reported that the ED visit wasn't necessary or that it made things worse. The same study concluded that the top possible diversions across all means of arrival that year were mobile crisis outreach teams at 98%. We want to shift from a risk-averse medical model that requires evaluation and treatment in the emergency room for behavioral health needs to believing and understanding we can keep kids, even those with some level of risk, safe at home and in their communities. Next slide. Through a recovery lens, MRSS is delivered to the family at home and through a system of care lens. In some regions, people call the provider line or the regional crisis line to access MRSS, like in the green box in the bottom right. Anyone can make referrals to youth MRSS teams, and they'll respond wherever the youth is. This slide shows 988 in the top right in that blue box. You may remember that I said National Suicide Prevention Lifelines who are answering 988. They are confidential in nature. And the Crisis Contact Center hubs, they're in orange, that will eventually dispatch youth teams are future state. We are working to ensure 988 can identify calls about youth or from youth to get them connected to MRSS teams. We don't want parents and caregivers hanging up and calling 911 to get an in-person response. We know that leads back to the emergency room. We don't want families telling their story over and over to access MRSS teams. We want the right intervention delivered at the right intensity and at the right time. Next slide, please. And here this is the last slide for me. I've provided the regional crisis lines for your reference so that you can have quick access to them. Thank you.
Thank you, Sherry. I know this is a really big body of work for you and really important work across the section, so thank you. Before we go to the Q&A section, as Liz said when we started this meeting today, the work of this team is very robust, and this is just a snapshot of the things that are being implemented throughout the year. So we have included the rest of the programs that this division supports. And so you can read more about these. These are all linked directly to their programs. So if you want to get to know a little bit more about us and what we're up to, this is a great resource page for you. With that, I'm going to stop sharing my screen and we'll go to the Q&A section of the meeting.
Yes, and now that you've heard from us, we'd love to hear your thoughts and questions. Yeah. Happy to take feedback on things you'd like to make sure we're considering as well. And while we may not have answers today or at all, we'd love to hear your thoughts, comments, and just any wonderings you might have about things. And I do see that there was one question in chat for Sherry about just confirming that Snohomish County has no MRSS teams.
Snohomish, someone remind me where that county is. Isn't that in North Sound?
Getting the nod.
Yeah, I think Snohomish does have youth teams. I'm not looking at the map right now, but I believe they do.
Let's see.
And then another question in chat, and then I'll stop reading the question. Are the crisis lines administered through the BHASOs?
Yes, HCA, we contract for crisis services, including crisis lines, mobile crisis outreach, and DCRs through all the BHASOs.
There's also a question if we can share the link, Sherry, from you as well. So I will get that and definitely get that over to you, Brittany, as well.
I see a next question regarding PCAP. And the question is there any possibility of part-time PCAP programs? I'm in Stevens County and it can be up to 4 hours to Spokane if they even get into the program. So I serve Stevens and Ferry, and I do not know how to pronounce that, Pend or Oriel, with maternal mental health and family therapy, as well as teaching dual classes in the area. For part-time PCAP program.
That's a great question. At this time, we don't have anything that would be considered part-time PCAP, but I am always curious about the expansion opportunities for Spokane, because we know that the population out there expands beyond the Spokane walls. So I will take that into consideration and share that with Spokane directly. And I really appreciate your feedback.
I have been working with Dr. Stone and Dr. Monica on this over the last couple of years through my master's program. And so I'm just really wanting to expand that program up this area. Ponderay and all this up through here, we're a horrid service desert, even into Okanagan County.
Yeah.
So thank you.
Oh, no problem. Just to expand a little further, we have kind of started experimenting with what we call satellite sites for the larger programs. So for example, King expanded capacity by moving some of their capacity down to a smaller location in Southern King, so they can assist clients there. And so it's a new thing and we're really kind of exploring it. But I could see Spokane being interested in the future with something like that. I think that could very much be a possibility.
If I may make one last comment, the midwife nurse practitioner that I am working with here in Colville, she also has a practice in Spokane Valley. And when this home is completed, a renovation here in Colville, she is going to purchase it, and we will then be hosting a sort of maternity home with some wraparound case management services. So we've already been working with our Rural Resources for Housing, and they will be supporting that as well. So we have a program that we are in the process of building that would be right up in that line of being able to expand with maybe a satellite type space and services in this area.
Thank you. That's great news.
There is a question for the group. Noticing that many of the services area maps presented today did not provide services available in Central Washington. Is that a main barrier preventing the expansion into these regions? Open to the team.
And so happy to take feedback if folks have program specific barriers with the region. And Rochelle, I think this is one that we can bring to our larger section and see if we can pull out some themes in the future. That's a great question.
Yeah, Rochelle, I can say that North Central has 2 youth teams, and Greater Columbia region has 1 youth team, and they're building a 2nd team. So those rural regions are actually surprising us. They're standing up more than 1.
I have another question for Sherry. For the MRSS teams, do they commercially serve insured youth?
They can. So the way that they can achieve this is through that unsustainable local braided funding. So Thurston Mason serves all youth insurance blind through local tax funding. That 1688 Balanced Billing Act requires that commercial carriers will start paying their fair share. So we're working on how we can incorporate that into MRSS with the Office of the Insurance Commissioner.
One for Rachel Baxter on YART. Where do you typically see the majority of your referrals?
Yeah, so the limited amount of referrals that we've received have majority have came from the emergency departments currently. 8 of those that we have received are also involved in a behavioral health setting in some capacity.
Well, we're about at time, so I want to thank you guys for joining us today. We will be doing another one in November, so be on the outlook for those in your inboxes to join us. You can also find everything that you would need to learn more information about us on the HCA Prenatal Child and Youth Adult Behavioral Health Services page. All the links are in the slides that I have linked to not only this presentation, but will also be on the web. You will get a follow-up with me via email, probably sometime tomorrow, with all of that information as well. And with that, I thank you all for being here today. I thank the presenters for helping me stand this up and supporting your work. I'm always highly impressed, not only at HCA, but for those of you providers and everyone else who helps our work become meaningful and assist in all of you. So have a wonderful day, and we'll see you next month.